A 35-year-old woman, G1P0, at the 10th week of gestation comes to the clinic with an abundant lower genital tract bleeding. The patient describes mild cramping on movement. The clinician decides to pursue a speculum examination, seeing an open cervical os and fetal tissue exposed. What is the best next step in the management of the patient? A. Administer misoprostol. B. Dilation and curettage. C. Pelvic rest for 24 hours. Or D. Cervical circlage. These questions on USMLE are quite tricky because there are multiple types of spontaneous abortion. The treatment of the spontaneous abortion is dependent on the type. The answer is dilation and curettage. The patient presents with the classical findings of an incomplete abortion. This consists of mild cramping and bleeding. On the speculum examination, we have viable tissue. The treatment is dependent upon the gestational age. Less than 12 weeks, we do a dilation and curettage or manual uterine aspiration. More than 12 weeks, we administer misoprostol, or we have an expectant management in the hopes that she will eliminate the product of concept. Firstly, we have incomplete versus inevitable abortion. On the physical exam, both are with an open cervical os and both have mild cramping and bleeding. From the diagnosis part, we should see the product of concept on ultrasound inside the uterine cavity. Now, the differential diagnosis between incomplete and inevitable abortion is the fact that the fetal tissue hangs out of the uterine cavity in incomplete abortion. In the case of the inevitable abortion, the fetus is still inside the uterus. The treatment is, as we've discussed, dilation and curettage or manual uterine aspiration at less than 12 weeks. More than 12 weeks is a treatment with expectant management or misoprostol. And if we have inevitable abortion, we use the treatment from the incomplete abortion from 12 weeks on. There is also a threatened abortion, which also has an open cervical os and bleeding and cramping. For the diagnosis, we will have the fetus inside the uterine cavity on the ultrasound. However, the treatment for threatened abortion is a pelvic rest for 24 to 48 hours. Then we follow it up with ultrasound to see if it either developed into an incomplete abortion or inevitable abortion, or if the threatened abortion actually remitted. Easiest concept is the complete abortion. On the physical exam, the cervical os is closed. The bleeding is already resolved by the time the patient arrives in the ED, and there is some mild cramping. However, the diagnosis is made with ultrasound with no fetus inside the uterine cavity. It already underwent expulsion. And the last type is the missed abortion. We have a closed cervical os, we have no bleeding and some mild cramping. However, the fetus in this case, although present in the uterine cavity, has no cardiac activity. In this case, we either expect the expulsion or we administer misoprostol to induce expulsion.